Hey guys, this is Theo Blackwood of Blackwood Vascular. I am making an educational video here regarding um, the different types of medications that you usually see if you're a vascular patient. And the reason why we do these videos again is because patients don't have enough time to talk to the doctors about exactly why they're on which medication. Today I had a number of patients in the clinic, in my morning clinic, and different people on different things, and they had different questions about how long do I stay on this versus how long do I stay on aspirin versus Plavix. And it's all about this video is all about blood thinning and just the general principles. Right now, state of affairs in America is you have and this is all my opinion, right? In general, these are generalizations. So you have single antiplatelet therapy, meaning that you're just on aspirin or you're just on Plavix, and essentially that's for the stable patient with stable peripheral arterial disease or stable coronary disease. These people are at low to moderate risk. You will cut down the risk of a really bad event happening, like a heart attack or losing a leg, and the good part of it is that the bleeding risk is low. Then you go down to the second category, people who've had a procedure, either a coronary stent or a heart bypass or leg bypass or leg stent, and in general, that's when you move into like a dual antiplatelet therapy. So you may have aspirin, but you add on something like Plavix or some other antiplatelet medication. You use those short term, and then you cut back down to the aspirin only as you get back to more a stable situation. And the reason why is the benefit of doing that second medication is you lower the risk of a stent or graft clotting, but at the same time you do increase the risk of bleeding. Finally, in the third tier, you have sort of a high dual pathway inhibition group, where people who have very high risk PAD patients, my vascular patients who have symptomatic leg problems, or they just finished a bypass and they have critical limb ischemia, just like the leg is really bad or the heart's really bad, and you got to save this graft or whatever it is, and long term they need this medication. And those people, you give them low dose anticoagulation. So this is not somebody who has active clot. This is somebody who is just very high risk for a stroke or a leg problem or a heart attack, unstable patients. And you give them these additional low dose blood thinner plus some antiplatelet medications. And the reason you do that is to lower the risk of these bad events happening, and but it does come with an increased risk of bleeding. So that's the general trend that we see right now. And then there's people who are actually on blood thinners as the last